Well, hi everybody. We had a little bit of technical. Somehow they don't like Safari, but they like Chrome. And we're going to talk about headaches and CGRP. I've written some articles about CGRP and pluses and minuses, pros and cons. So I was going to talk a little bit about some of the common questions with CGRP, and then I might talk a little bit about how we approach headache patients, why I call it deconstructing the art of headache medicine. We have about 50 inputs. Why does one person end up with a top 10 therapy list and another person, even a twin sister, might end up with completely different? And mostly I want to answer questions about CGRP. So after we finish, please type in any questions about CGRP, etc. So one question, do we see depression and anxiety as a result of the CGRP treatments? And sometimes we have. Now, technically, these are large molecule injections, large molecules that get into the body that don't cross into the brain. We call it the blood-brain barrier. But there are some areas of the blood-brain barrier that are not protected, or of the brain that are not protected from even these large molecules. There is some penetration into the brain, although pretty small. And we have seen central psychological side effects, anxiety, depression, for whatever reason. There's a lot we don't know about these medicines. Another question, we're seeing a small but significant percentage of people reporting that migraine attacks get worse with CGRPs. We've certainly seen that. And it does go away, but we have to stop the medicine. Sometimes we see it worse for 3 to 5 days or a week after the injection, and then it's better, and then headaches are better. So in general, though, if headaches are worse for 2 or 3 weeks or a month, we don't want to continue. We're not sure why this is, but it's another side effect among many that did not show up in the various trials for the 4 companies. The same goes for bloating and weight gain. We did not see much bloating. If you look at the trials for CGRP versus real life, there are much differences in side effect profile, and bloating and weight gain are one of them. We've seen some weight loss. I'm not quite sure why it would be from CGRP injections. And sometimes if you give 300,000 people a medicine, like 300,000 people worldwide, recently these grew out of the United States and went to the rest of the world, Canada and Europe particularly. As you see 300,000 people, 500,000 people, it won't be too long before we'll have 700,000, a million. We're going to see more odd side effects that did not show up in the studies. There's a big question, why don't all these side effects show up in the studies? Why did they just show up in real life? And I think there's about 10 answers for that. Constipation is an issue, of course, with these, probably more from Irritable, which was Aimovig, the original one. Irritable or Aimovig is a receptor blocker. So there's 2 parts really to CGRP. There's the CGRP itself, which is sort of a complicated large molecule made of 3 components or so. And then there's the receptor, which CGRP is actually simpler than the receptor, is made up of 3 components. So the CGRP attaches to the receptor and then it works. You need a receptor for a compound like this to attach to, and then it will exert its physiologic activity. If the receptor is blocked by Aimovig, by Irritable, then CGRP won't work and you have less inflammation, less headaches. The other 2 medicines, actually the one that also is going to come next year, Alder's intravenous, all these attach to the CGRP itself. So they don't touch the receptor. And there's a lot of different physiologies between these. So we may see side effects to one of these, to the receptor blocker, Aimovig, and not to the others, and vice versa. So we're seeing how all of this plays out. Do we see an increase in heart rate is one question. Probably not so much heart rate, although theoretically there's a lot of CGRP in almost every organ. And evolution has deemed CGRP very important as a molecule for inflammation around the head, but also some positive things that it does, like protecting from wound healing, protecting the heart and the brain from stroke and heart attacks. So we can't pretend that we're going to have no side effects going forward if we use these for years or decades. But we haven't seen much in the way of increased heart rate. Higher or lower blood pressure, I've seen a few people more with higher blood pressure. And blood pressure, CGRP is very important with blood pressure, but it hasn't been a huge problem. Even people with high blood pressure have gone on these and have not had a major problem in general. Hair loss we've seen. Nobody has any idea why. I think it's a real phenomenon. And hair loss is difficult. If you send 20 people to a dermatologist for hair loss, you're likely to get 19 or 20 back where they said the dermatologist had no idea. And we use sometimes Centrum Silver, which is a multivitamin with some extra zinc, or sometimes we'll use biotin, certain B vitamins, but hair loss is a very, very tough thing. Vision changes, one person asked about. We haven't seen that much in the way of vision changes. A lot of medicines cause vision changes, amitriptyline and all the antidepressants and topiramate can. Not so much the CGRP ones. And other side effects, yes, we've seen a smattering of all kinds of side effects. Constipation is the biggie. Sometimes we have joint pain and tiredness. Sometimes we have had depression or increased headaches. Most people have mild side effects to these, if they have side effects at all, and they go away. Now, we have to put this in context that all medicines do have side effects, and topiramate, for instance, can cause kidney stones and severe spaciness and sometimes anxiety, depression, bipolar. Antidepressants have all of their whole slew of side effects, all of the anticonvulsants. And many of the blood pressure medicines that we use for headaches cause this and that, particularly tiredness and weight gain. So it's not as if, well, one class of medicine has side effects in 10% of people or 20%, we're going to stop it. If you look at LASIK, for instance, LASIK for nearsightedness, 1 or 2% of people have severe side effects, and they have all kinds of halos and they can't see at night. LASIK is still popular. So it's really risk versus benefit, and we're going to know more over time. Another question, are side effects more common in certain comorbid conditions such as fibromyalgia? And people with headaches often have a very sensitive central nervous system, and we call these central sensitization syndromes. They often will have 1 or 2 or 3 other central sensitization syndromes. So the other ones are fibromyalgia, which is chronic widespread pain for at least 3 months, chronic pelvic pain, which has other older names that have not been that accurate. And chronic pelvic pain is not that uncommon. It happens in men also. We have CRPS, which used to be called reflex sympathetic dystrophy, where people have pain and numbness and sometimes skin changes in a foot or a knee or a hand, particularly after a surgery or some injury. We have irritable bowel syndrome. Most of our serotonin is in our GI tract, and the serotonin system in people with migraines doesn't quite work right. So a lot of people have IBS, irritable bowel, which is they'll get cramps, they'll get reflux, they'll get constipation or diarrhea, or one or the other, or flipping back and forth. If it's more constipation, we call it IBS-C, IBS with constipation, and in that case, we may not want to use the CGRPs as much because they can enhance the constipation. So these central sensitization syndromes are more prevalent in people with migraines, and a lot of people with migraines have 2 or 3 or 4 of these, and they have a very sensitive nervous system. They may have POTS, P-O-T-S, as a youngster, and a lot of people with POTS outgrow it, but POTS is where you have, it's called Postural Orthostatic Tachycardia syndrome. As they stand up, their heart rate goes up, and sometimes blood pressure drops, and we treat it with certain medicines. That's common in people with migraines. So if you have a central sensitization syndrome, chronic migraine, irritable bowel, chronic pelvic pain, reflex sympathetic dystrophy, or CRPS, IBS, what happens, or TMD, TMJ, TMD, where you have clenching and grinding. It's not as if you wake up that morning and you just decide, your muscles say, I'm going to clench and grind. It really comes centrally, more from the brain and spinal cord. If people have 2 or 3 of these, they have a very sensitive nervous system, and they're going to have more side effects from certain medicines, particularly the CGRP ones or any of the migraine medicines. So we go slow and low with medicine. But many of the more prevalent side effects that we've had are people who don't have central sensitive nervous systems, who have no fibromyalgia. They just have migraines. They go on these drugs and they get tired or joint pains or constipated or worse headaches, etc. Another question, have we seen problem with healing, inhibition of wounds? In theory, CGRP medicines can inhibit healing and decrease healing. I haven't seen that much. In theory, we should be maybe tapering these off before surgery. Burns, CGRP is important in healing burns, but clinically, we haven't seen too much of that or heard of it. Another question, if a patient tries Emgality or Ajovy, which are the CGRP blockers itself, not the receptor, they're what we call the ligand, the CGRP itself. If they've tried Emgality or Ajovy, one or the other, and they have no results with a lot of side effects, is it worth it to try the other? And that's $1 million question. I'm doing a long study. I published one recently on Aimovig and the pluses and minuses over a year, and it's been pretty good, but there's some side effects. And now I'm looking at Emgality and Ajovy and what happens when we do switch from one to another or from Aimovig to these. I think that if people have a lot of side effects to one CGRP, to Emgality or Ajovy, because it is a CGRP blocker, they'll probably have the same side effects to the other. This is not proven yet. Or if they have no efficacy, no effectiveness from one, they may not get from the other. Now, in other classes of medicine, if people don't do well with one SSRI for depression, if they don't do with one beta blocker for blood pressure, they may do well with another one. So it doesn't necessarily mean that we have to just stop the medicine or not switch. But in general, if people have side effects to Emgality or Ajovy, and they're more than mild, I'm not switching. I just don't think that it's, in my experience, I've had side effects to the other. One question that's come up, are the medicines contraindicated, or should they not be used in people with immune problems, such as, immune deficiency or CVID, or even in overactivity like lupus or rheumatoid arthritis? So the immune system in migraine goes way back. And back in 1988, I was just in practice a few years, and I became convinced that the immune system was a key in headaches. We did some studies on helper suppressor cells and found some interesting things. And it is, CGRP in the end works on the neuroimmune system and is an immune blocker in that way, and it dampens down that immune response. What happens is you get all this inflammation around the head. You get a release of all of these inflammatory proteins that feed into the bottom of the brain, and it goes up into the brainstem and up into the brain and tells your brain to have a migraine. If we can cut off that inflammation out around the head and block CGRP from starting the inflammation, it can work on headaches, and that's indeed probably why this is working, although we're never quite sure mechanism of action of why a lot of these work. 20 years after triptans were out, sumatriptan and rizatriptan, Imitrex, Maxalt, and the 5 others, we were still not sure where they worked and how they worked. So it's not always clear how something works. Topiramate, Inderal, amitriptyline, we're not 1,000,000% sure why they really work in headaches. So the CGRP medicines, I still have some questions. For instance, these have long lives in the body, long half-lives. Generally, the half-life, which is the amount of time for half of the medicine to go out of your system, is around a month with these. And once you're at steady state where these are in your system, they should last quite a while in your system. But we have a number of patients, and I've seen this on the chat boards, and I'm on headache chat boards with physicians, where the medicines stop working after a week. They work for a week or two, and then they stop working. That theoretically shouldn't happen, but that tells me that there's a lot we don't know about why these work and why these might not work. So there's no absolute contraindication with immune deficiency or CVID or with lupus or rheumatoid arthritis that we know of yet, but we are using them. One question came about, how about using lower doses for people who are sensitive to meds in general? And I'm big on lower doses, and I like low doses. And we tiptoe along with teeny doses. The problem is practically we just have one dose for these, except for Aimovig, where we have the 70 and the 140. So we can use 70 milligrams instead of 140 in people with Aimovig. But Emgality is just one dose, and Ajovy is just one dose. What I do clinically is with Emgality, you're supposed to do 2 of the shots to begin with. It's called a loading dose, 2 of the 120 milligrams. But I tend not to do that, because if people are sensitive to it, I'd rather start low and take another month or 2 for it to work rather than risk side effects. So we can use a lower dose with that. But in general, I like low doses and I like minimizing dose. One question is, a person did write in about her blood pressure is increased on Aimovig since June and it's gone up a lot. It could be due to Aimovig, and it could be from high blood pressure. If there's a family history in middle age or older, any weight gain, often high blood pressure is extremely common. The only way to know is to go off the Aimovig and see. We'd have to wait. Some other questions. The safety of these medicines with people with faulty heart valves. There have not been shown to be problems. We don't know conclusively. But with stroke, I think that in somebody post-stroke or at high risk for stroke, I would tend not to use these. I have seen reports in a few people, now this is out of 250, 300,000 people, of stroke. And I think that it's a theoretical risk factor. But again, I think it's going to be fairly rare to get something like that. Also in congestive heart failure or other cardiovascular conditions, that's $1 million question. If somebody has bad arteries in their heart, they're at high risk for a heart attack. I've been not using these. I've been holding off. Now, sometimes nothing else works. I think if you look at Botox, for instance, it's very safe. We started using Botox 23, almost 24 years ago, and it has 25 years of safety, actually, in the use of headache. You just never see anything bad happening with Botox. So I'm much more likely to use those in people with heart attacks or risk for stroke. Botox is not going to be any problem. But in reality, we've not seen very much in the way of heart problems or anything like that with the CGRPs. But that's not that it can't happen or that it won't happen in the future. One question about a washout, if people are, which means how long should you wait if they're on one CGRP to start another? Every doctor does this differently. I tend to wait 5 weeks after the last CGRP. Some doctors are waiting 2 months or even longer. Some are just waiting them 1 month and not worried about it. And clinically, we have not seen a problem switching to another one. Another question, is it possible to have CGRP stop the pain of migraines, but not the associated symptoms, the nausea, sensitivity to bright lights, loud sounds. And that can happen. That can happen with triptans or any medicine or any preventive where you end up stopping the associated symptoms, but you still have the pain, or vice versa, and that can happen. Have we had success with TBI, which is traumatic brain injury, post head injury, post concussion? And I have not. In general, if patients have non-migrainous headaches, if they have chronic daily headache without migraine features, post-traumatic, the worst headaches, the most difficult to try are new onset daily persistent headache, NDPH, where people just start having headaches one day for no reason, or they might have had a viral illness or a surgery or big stress or a head injury. These are tough to treat. And if they're not migrainous, if they don't have migraine features, it's very difficult, and these drugs don't seem to work. Botox sometimes will work for those. We haven't had much luck. Likewise with cluster headaches, we have had some luck, and Emgality has a potential, it's 99%, I feel, FDA approval on cluster, episodic cluster anyways. We've had some luck with cluster headache. Cluster and migraines are like cousins to each other, so they're similar. Does it help body pain that comes with migraines? If the body pain is associated during the migraine and with migraine, often any drug that helps the migraine will help that. Hemiplegic migraine came up. Now, hemiplegic migraine is severe neurologic deficits or problems on one side usually, or coordination problems, visual problems, numbness, weakness with a migraine that are severe, that last usually more than 20 or 30 minutes, like with an aura. And I would tend to stay away from CGRPs. I think that the risk for stroke is too high. We definitely recommend staying away from that. There's a question about alders that's coming. The 3 that are out are subcutaneous injections. Alder has one coming out early next year, probably, if it's approved, and that's not for sure, but that's intravenous every 3 months. It's a little stronger. Their data is a little stronger. That it works reasonably well, and I think that there's going to be a good role for the alder. It is every 3 months. You have to go in for an IV infusion. There's a question about AJOVY and the immune system. We haven't seen too much problems. There are some people with rheumatoid arthritis on Humira or Enbrel, or multiple sclerosis on monoclonal antibodies. These drugs are called monoclonal antibodies, the CGRP ones, and there's about 75 or more in use now for MS, for rheumatoid, for various things, for itching. And we haven't seen too much as far as interactions with these, and theoretically they can be used together. Theoretically, these can be also used with Botox also. There's a question, can you take your medicine 3 or 4 or 5 days earlier? And I think that absolutely you can. There shouldn't be a big problem. It doesn't have to be exactly on the day. One question is, do these keep working over months? In my studies, sometimes they stop working. I think that pretty much at the end of 2 months, you can predict if somebody's done really well, they're probably going to continue doing well, but not always. If they've done terribly and they've had no results from their headaches, then it's unlikely for them to get better in months 3, 4, 5, and 6, and we tend to switch. I like to give these 2 or 3 months, but I don't think we have to wait 6 months. A lot of people do have great results from these. They're super responders or excellent responders, we call, and I'm studying any predictors of why people might have excellent response versus non-response, 0 to 10 or 15% response. The only predictor, we looked at 20 items, psychological, medical, neck pain, that seemed to predict poor response was daily opioid use. You're more likely to have less response, or severe refractory headaches. If people have, I separate refractory, which is difficult to treat, headaches into mild, moderate, and severe. Severe, say, is 40 years of headaches with multiple medical problems and central sensitization like fibromyalgia and everything, and nothing's ever worked. And people are on daily opioids. Severe refractory, people are less likely to respond to these. One question is, after 3 or 4 months, should I switch off AJOVY or what happens? And I tend to switch. I don't think continuing these forever. It's just like the preventives, like topiramate or propranolol or amitriptyline. We want to give them a month or 2 or so, but we don't have to give them forever. Joint pain and tiredness are unfortunately seen with these, and it's all too common. Sometimes it's moderate or severe. Sometimes it gets better. Sometimes not. There's a question about menstrual cycle being impeded or changed, and depression, anxiety, and I think that does happen. So these are protected from going into the brain by that blood-brain barrier, but there's several crucial areas that are not protected from the blood-brain barrier. The hypothalamus, where we have all those hormones, and the pituitary gland, where we have all those hormones. So there are hormonal issues that I think can happen that did not show up in the studies. Similarly, there's a question about nausea, and there's an area, it's called the area postrema in the brain that's not protected from the blood-brain barrier. And these can enhance nausea because that's your nausea center in the brain. Nausea from migraines tends to come from the brain, not from the stomach or lower down. So sometimes these can impact nausea, and sometimes we've seen it severe. Usually it goes away, but not always. One person said that the Emgality made her bones ache very severely and migraine pain 100% worse, so we immediately stop it. If things are that bad or much worse after 2 weeks, I tend to stop and not continue with the medicine. There's a question about mast cell activation syndrome. So mast cells are part of your inflammatory response. Mast cells, if you activate them, they release these inflammatory proteins. We call it the inflammatory soup, which is bradykinin and histamine and substance P. Never order the inflammatory soup when you go out to dinner. So mast cells will trigger the release of inflammatory soup. And some people, these are very active and they're constantly releasing, and they get allergic type symptoms, but they get often migraines. And back in the late 80s, I decided what can affect mast cells? How can we decrease them? And we had people breathe in heparin once a month, and or once a week, it actually worked for their headaches. So it's interesting that somebody mentions mast cells. They are important in this whole immune cascade. Bruising, you can get bruising, but it's not very common with these. We haven't seen it. One person, their heart rate did slow down extremely. There was a few case reports, but not very often. And one person, AJOVY didn't help, and they switched to Emgality. I think that we have the Aimovig receptor blocker. We have AJOVY, Emgality, and they have really different profiles. So if somebody doesn't do well with one, I tend to switch to a different type. One person's not getting much benefit on 70 milligrams of Aimovig, so we would increase it to the 140 milligrams. So Aimovig, you used to do the 270 milligram injections. Now they have 140 milligrams, which is a little bit of a disadvantage because now we can't order 70 milligrams. Some people, these worked for 2 weeks and then stopped working. And so we actually did 70 milligrams every 2 weeks in some people with Aimovig. It's off-label. I'm not sure that even worked, but now you can't get the 270 milligrams. You have to get the 140 milligrams. Hair falling out is a common question, and we've seen it. And if it's from a drug, we just have to stop the drug and see. Losing effectiveness over months, I've not seen it get better if we just continue that drug, so I tend to stop it and do something else, either switch to a different CGRP or go back to something else. Now, somebody says Aimovig is a godsend and they've had no side effects, and we see that quite a bit. We see in the studies, the side effect profile in the studies, I think, has not held up. And the side effects profile is turning out to be much different than the studies, and there's a lot of reasons for that. But the effectiveness is sort of the same. About 50% of people get 50% relief or better. There's a group of people, 10, 15%, who get an excellent response, sometimes almost no headaches, and then there's no headaches, and then there's a group of people who get zero response. So if you're an excellent responder, it's wonderful. But if people have severe refractory headaches for many years, and it's 24/7, and it's 30 days a month, and they get 25% better or 20%, it can change lifestyle, it can change quality of life, it can be good. There's a question about knee replacement surgery on Aimovig. In theory, these can inhibit healing. In practice, I'm not sure that we've seen very much of that. There's a question about placebo. Of course, placebo comes in quite a bit. It tends to go away, the placebo effect. So placebo is a real effect. If I say this sugar pill is going to work and I give it some fancy name, it may very well work for pain. You put out your internal opioids, your neurochemicals are changed, and they can actually measure that. But it doesn't mean that that effect is going to sustain itself. It tends to go away after a month or two. There's also the nocebo effect. So if the doctor says, it's the opposite of placebo, says, well, I'm going to give you this, but it may not work, and it tends to have a lot of side effects, and you may get dizzy and tired. Well, you may very well get dizzy and tired because a lot goes on in the brain, and this can be imaged with brain imaging that goes on. There's also the placebo by proxy, where if I mention topiramate and mom says, oh my God, that was the greatest drug, her daughter, 18-year-old daughter, Heather, I might give it to because there's a genetic component with moms and daughters and parents and kids with drugs. And there's also the placebo by proxy and also the nocebo by proxy. If something almost was terrible for mom, I won't give it to the kid. The question is Aimovig with Xarelto, which is a blood thinner, and there haven't been contraindications talked about yet. Somebody said that their headaches are worse when they come on the CGRP meds. When they do occur, their migraines are more violent. That can happen. But more often, these CGRP meds make the migraines less severe when they come. Some people get the same amount of headaches, but they're less severe, and it's really worth it. There's another question about a woman who is a super responder for a number of months, and then the headaches are coming back, and it may lose effectiveness or may go month to month. I'm looking at what happens each month over 8 months, and it can go off and on. Depends on what time of year we're in. Spring and fall are often worse. Weather changes, all kinds of other triggers that come in play. And sometimes they just all of a sudden lose effectiveness and we have to do something else. Chronic cluster patients can have success. I had one chronic cluster patient off-label go on Aimovig. He had had 50 years of severe headache every day, and he's had no headaches for 4 months on Aimovig. That was amazing. Nothing had worked, even an implant. Well, that had helped somewhat. But now the question of migraines and occipital neuralgia and CGRP. So about 1/5 of people with migraines have what we call occipital neuralgia, which is severe, sharp pain, the back of the head, going up the back of the head. It's tender often. And the issue is what to do about that. Often an injection around the occipital nerve will help, some medicines. I think that CGRP meds don't, in general, work for regular neuralgia type pain, unfortunately. There's a question of basilar migraines, which is neurologic effects with the migraines on Emgality. I think that there are more side effects possible, particularly I worry about stroke. and I don't use them with basilar or with hemiplegic migraine, but it's not officially contraindicated yet for that. With cervicogenic causes for headaches, so when people have arthritis in their neck or a pushed out disc, and the neck is really triggering more migraines, the CGRPs may work. It's not been looked at officially. The history of cancer, I don't think that CGRPs are contraindicated. Certainly, in theory, we have not seen a reason why they should be contraindicated in people with a history of cancer. New daily persistent headache, NDPH, several people have asked about. It's always the more severe, it's tougher to get at, and the CGRPs could work if the new daily persistent headache is more of a migraine type component. If it's throbbing, if there's associated symptoms, if it's just chronic daily headache, aching, hurting, no throbbing component, no associated symptoms like sensitivity to bright lights, loud sounds, dizziness, well, the CGRPs are a lot less likely to work. One person has auras with silent migraines. I think migraine with aura is different than hemiplegic migraine. Migraine with aura, the aura is 20 minutes, 10 minutes, 20 minutes, 30 minutes, and it's flashing of lights or sometimes visual problems off to one side, maybe a little numbness. That's different than hemiplegic migraine with severe neurologic deficits that go on. So migraine with aura, people have been using CGRPs quite a bit. I don't think that there's a major contraindication. Weight gain is a problem. Weight gain is always a problem from a medicine, and if it's from the medicine, we tend to have to stop it. Other medicines are worse probably than the CGRPs, particularly the beta blockers, Depakote, and the older tricyclic antidepressants are worse for weight gain. Migraine-associated vertigo can get better with CGRPs if it's migraine because the CGRPs are going after the migraine process itself. There's another question about weight gain and increased hunger. And unfortunately, with these, except for Aimovig, we can't cut down on the dose because with Ajovy and Emgality, it's just one dose. Another question, no migraines, but the pharmacy won't refill it, even though the headaches were better. Getting these paid for is a big issue. So when we look at how do we treat one person versus another, we look at finances are a big issue. Can we get the meds paid for? With these, they price this at $600 a month. In context, the meds like Enbrel, Humira are $3,000 to $4,000 a month. So since they price these relatively low for monoclonal antibodies, most insurances are on board, even some Medicare insurances, but not always. So unfortunately, sometimes even the appeal doesn't work. Sometimes we look at which insurance and it'll be second line or third line on this insurance. One of these Aimovig will be and not Ajovy or vice versa. So we have to go with the CGRP that insurance allows. Hemiplegic migraine is tough to treat. Sometimes we use preventives like valproate, beta blockers, amitriptyline that might cut down on the cortical spreading depression, we call it, cut down on the brain firing. Certain anticonvulsants can do that, and verapamil is often used. Now, the two most commonly used ones for hemiplegic migraine tend to be verapamil and Depakote, but there's not heavy evidence for that. It's just more anecdotal. There's a question about using DHE nasal spray. DHE is a very safe compound. It was invented in 1945. It doesn't really shrink the arteries, but the DHE nasal spray tends to stuff up the nose and doesn't work that well. The triptans are first line, so we want to use triptans. There are 7 of them: sumatriptan, rizatriptan. Now we can get them fairly cheaply through GoodRx, so you can get 30 of them for about $30. So we tend not to use DHE unless the triptans haven't worked. There's a question is if we build immunity to one CGRP, should we switch? Certainly we can switch. If we've had no response at all from Ajovy, I do switch to Emgality sometimes, but if they've had a lot of side effects to one, I just quit and do something else. There's a question about ulcers with these. In theory, these medicines may inhibit healing of ulcers, and they do affect the GI tract. There's a lot of CGRP in your stomach and your GI tract, and they could inhibit healing of ulcers in theory. Whether we really see that is questionable. Now, the question is, if Ajovy does not work, we might go back to Aimovig because of the it's a different mechanism of action. One person had a history of transient ischemic attacks or a mini stroke, and they had some heart flutters and problems from Aimovig. I'm not sure I would pursue this line of medication. I would probably quit and do something else. Now, sometimes people have tried everything else or a lot of things. Itching can occur, but it's not very common with these. You can get allergic reaction to anything. A history of cancer, we did answer, and I don't think that it's really a contraindication, but reflux. A lot of people have reflux with headaches or in general, and these tend not to make reflux worse, like a lot of medicines will. Now, in context, if you look at our anti-inflammatories, Advil, Aleve, even Excedrin with aspirin, probably 80% of all our side effects are from the anti-inflammatories. And last year, about 70,000 people, actually, anti-inflammatories contributed to their death in this country. So in context, the CGRP meds may be actually safer than anti-inflammatories long-term, despite all my yapping about possible side effects. There are a number of questions about new onset daily persistent headache, and I don't think that it's great unless people have migraine type new onset daily headache. If it's just a regular plain chronic daily headache, these have been disappointing. Another question about daily auras starting with CGRP. So somebody starts on one of these shots and then has an aura every day with either vision flashing or losing their vision or numbness or weakness, and I would stop the medicine. Daily auras can turn into a stroke. We worry about it, and I don't want to continue, particularly if people are on the birth control pill and or are smokers. There's another question going from 12 migraines a month to 4 or 6, and that's common. That's your 50% better. And if somebody has 20 headaches a month and we help them 50%, they still have 10 migraines a month. So we may want to try another preventive, whether it's Botox or a daily preventive, oral. But we've gotten a long way, gone a long way in quality of life, going from 20 migraines a month to 10 that you have to hassle with. I do think that medication overuse headache is overdiagnosed. It's poorly defined. And there was a question about that. A lot of people are designated as medication overuse headache or withdrawal headache or rebound headache. But is it true, many people who are told they have that, they don't actually have it. They may have medicine overuse. They may be using a lot of Excedrin or triptans or Furanol or even opioids. But to prove that people have medication headaches from that medicine, we have to take a careful history, take them off the medicine. It's much more complicated. So these can work with medication overuse headache, though. If somebody's on a lot of Excedrin, these CGRP medicines can work, and they're certainly worth it, even if they're not getting off the Excedrin. We always try to minimize the as-needed medicines, though. But in people with 4 headaches a week, if it's the only thing that works, we'll use the triptans, because what's the alternative? People say, well, you tell me the doctor says only take something once or twice a week, but I have 3 kids and I have to work. What do I do the other 4 days a week? And if sumatriptan or something's working, we just use it, unless we're sure that it's causing rebound headache. Weight gain seems to be a common issue or question, but we haven't seen that much, but occasionally it happens. I'm not sure the mechanism, other than our weight and our feeding and our hunger is centered in the hypothalamus. And the hypothalamus, which has all these crucial hormones and areas, is not protected by the blood-brain barrier from these medicines. So they do get in there. The newer GPANs, which are CGRP medicines that'll come out in a while, they're called GPANs as opposed to CGRP injections. They're different. They're small molecule, so they do get into the brain. They probably have more side effects. And they're mostly going to be used to abort or stop a headache in progress. The effectiveness of these is going to be mild. They don't work as well as triptans in general, but they don't shrink the arteries. If somebody is at a high risk for heart problems or stroke, the new GPANs may be safer in that population, and they'll probably be tried in people where triptans have not worked, but they're going to be a small niche. It's not going to be a miracle. They don't work. Their effectiveness is not as good as the triptans, unfortunately. Seasonal allergies do come in. Generally, headaches are worse in spring and fall, but everybody has their better and their worst season. And spring and fall, though, we see the most hospitalizations for headache, the most ER visits. And so a lot of people can tell the weather with their head. So there are some apps that tell the weather. Migraine X is one of them. It has a barometric pressure measure, and it says take your migraine medicine when the pressure is dropping if people are very weather sensitive. The top triggers for headaches, everybody focuses on foods because we're told, well, you eat this food, that food, but in reality, most people with chronic headaches discover 1 or 2 or 3 foods are worse for their headaches. Red wine and MSG sometimes, beer, occasionally aged cheeses and meats, but weather and stress are probably number 1 and 2. Insomnia or sleeping difficulties one way or another, missing a meal. These are all more than foods. Weather is probably, and stress are up there, number 1 and number 2. So with basilar migraines or severe neurologic effects with migraines, I would just not use the CGRPs. I'm afraid of them. There have been a few strokes. I'm just too worried about using these in people with moderate or severe neurologic problems. I know sometimes there's not other problem or reasons, but we have seen people who are on CGRPs who've never had Botox. Botox has a 23-year history, 23 in my practice every day, but 25-year history of safety. And I think that I would rather try to get Botox pre-authorized and do it because nothing ever bad really happens. We don't get the weight gain. We don't get the joint pain. We don't get this and that. Sometimes you have worse headaches from Botox for a week or 2, and then we might quit it. But in general, we don't have the problem. So I would rather do Botox. One question is, if somebody got severe headaches from Aimovig, should they maybe try Emgality or Ajovy? It's iffy. They are different. I would tend to try the other class. If they've had headaches, it may very well not happen from that one. Another question is, if these monoclonal antibodies aren't working, do the GPANs have a reason to work? And they work differently. So they both work on CGRPs. The triptans end up working on CGRP. So I think that even though these preventives may not work on somebody, it's worth trying the GPANs when they come out. But what I unfortunately have seen from the studies, and years ago I worked on some of the GPANs, the effectiveness is relatively low. They're not going to be a huge miracle for anybody, but it may be worth trying. And then there's lasmiditan. So it's more of a triptan that's a 1-HTF blocker as opposed to BND, which means it doesn't really affect the heart. So the good news with lasmiditan It's an as-needed abortive that is not going to affect the heart, unlike the other triptans, but the triptans have been out almost 30 years and are very safe in general. Lasmiditan, though, has a lot of dizziness. I'm worried about the annoying side effects with that, and it's not all that effective. So again, like the Gepants, lasmiditan is going to be mildly effective, worth it for some people, but not any great miracle. There's a question of upper respiratory or breathing issues with Aimovig, and somebody has allergy type symptoms and cough. It's definitely worth reporting. I think all side effects are worth reporting to the FDA, but whether it's related, it's been very rare and hasn't been reported very much. And another question about hemiplegic or basilar migraine, again, because of the higher stroke risk, I'm very reluctant to use these, even though they might help. I wouldn't be worried about the weight gain particularly. It's so much more with other medicines. If you go on propranolol or other beta blockers or tricyclics or even any antidepressant or Depakote or even gabapentin Lyrica, you're more likely to get weight gain than with these drugs. So it can happen, but it's pretty unusual. The question of TMJ or jaw problems associated with medicines, it's relatively unlikely that these will cause jaw problems. Whether they can help TMD, it's relatively unlikely. Botox actually helps TMD in a number of people, but not that much. There's a question of flu symptoms and pneumonia since starting HOV. And I don't think it's a direct allergic response. If it's a response, it's more from blocking CGRP, not an allergy to it. And the person does not want to stop it. That's always an issue. Say you have a drug where you get 90% response and nothing else has worked, but they have a bad side effect. You're reluctant to stop it, but sometimes you have to. Sometimes we just go along, or we might switch to a different type of CGRP. I myself don't think that they should be used with basilar migraine or hemiplegic migraine. Now, unfortunately, the FDA is slow to change the labeling and put different labeling. It may take a year or two or even longer. We're trying. I've sent some letters to the FDA hoping they would change. So the March 31st Erenumab Aimovig FDA reports came out on FAERS website, which is the FDA side effect website. And they had 12,000 side effects reported. That's in about 10 months, and 1,200 serious side effects. Now, whether they're all from the Aimovig, probably not. A lot are coincidental. But what it means is that we have significant amount of annoying side effects that should be in the package inserts of these, but it's going to take a while to update the package insert, unfortunately. And a lot of doctors are not aware because the original package insert to all of these has basically no side effects. So they say, well, there's no side effect. The poor patient goes and says to the doctor, I'm having this and this from the HOV or from the Emgality or the Aimovig. And the doctor says, oh, no, it can't possibly be that. Look at the package insert, there's no side effects. So that's the problem. We're not legitimizing what the patient says, and it's not realistic, the side effect profile. So if Botox helps partially, say 30% or 50%, you can add in a CGRP medicine and hope to get another 30 or 40%. If you have a partial response to one, say Botox, and you want to continue, it may be worth it to continue the other, or to add it in to try to get, so if you reduce headaches from 25 a month down to 16, and then you can add something to get down to 10 headaches, that's a big difference in quality of life. Post-concussion, 24/7 headaches are tough. Often not much helps that much except pain medicine, so we've ended up with some people on that. Sometimes the preventives work, and sometimes Botox works for post-concussion, but they're a tough type of headache to try. Sometimes it takes a village, to help a headache person. So we do physical therapy, massage, biofeedback, meditation, whatever works, sometimes psychotherapy. There's an issue, somebody who's lost 30 pounds on Aimovig. If it keeps going, of course, we have to stop the medicine. We don't want a huge weight gain. We don't want somebody to get too skinny. That's not good. Visual auras increased on Aimovig. Well, the Aimovig can somewhat get in the brain, and it's irritating the occipital lobe, starting those auras. I would have to stop the CGRP. One person lost weight on one and gained weight on another, and that points out these are different. If you look at the SSRIs, for instance, Lexapro, Zoloft, Paxil, Prozac, they all end up doing similar things, but a little differently. And people have a much bigger, different response to one than to another. Ear ringing, tinnitus is very common, and unfortunately, it can happen with any drug. What's more likely to trigger ear ringing and tinnitus is antidepressants and NSAIDs, Advil, Aleve, aspirin. So once people get ear ringing, they should see the ENT. They often have a little bit of hearing loss in the high frequencies, and they have to protect their ears. So no, it's little Tylenol. Tylenol isn't as bad as the anti-inflammatories or aspirin for ear ringing, but it's not great. Painkillers, we really try to minimize what makes it worse. Somebody has hair log and fatigue, hair loss, and pain in their lower back or possibly kidneys, we would tend to stop it. Any drug that causes more than one side effect like that, we really try to stop. So there's a question about managing migraines with triggers. We always look at triggers, trying to eat regularly, manage stress, et cetera, et cetera. But the problem with most of the headache books out there is they make it sound as if you just follow our program or you just watch these foods or whatever their magic solution of the day is, your headaches will be 90% better. And unfortunately, headaches are like asthma or diabetes. They're not psychological. They're inherited, genetic, a lot going on in the brain in people with headaches. You inherited a very sensitive nervous system. And in many patients, there's only a limited amount of things you can do. You can eat right, you can go to sleep, try to get enough sleep, you can work on meditation things and exercise. We push all that on everybody. But we don't want to blame people for their headaches, and we don't want to tell people that they're not in control of their headaches. There are things you can do, but we don't want to overstate that, oh, you have to know exactly why you had a headache for each migraine, and you can do something about it, unfortunately. Some people can, some people can't. Now, the issue is, should we wean off after a year? We used to do this with some drugs like Sansert, methosergide. We would take what we call a drug holiday and stop the medication after a certain period of time. There's no evidence that that will help with here. What I'm worried about is long-term side effects. We've been talking about short-term side effects, but long-term side effects are a huge issue. Are we going to get them? Now, Amgen and Aimovig has some pretty decent data at 5 and 6 years now. But it's a limited number of patients. It's been safe for that number of years. So over 10 or 20 years, once we get over 1 million patients, what's going to happen? We don't know. CGRP does a lot of good things. That's why I don't want to use them in kids under age 18 or even 20, unless we can really help it, because we don't know hormonally or other long-term issues. So long-term, it's a new class, and I always say use new drugs a lot while they're still safe. I was worried about Botox 30 years ago. 25 years ago, it turned out to be really safe. So maybe we'll get lucky. I hope we get lucky, and these won't have much or anything long term, just these short-term ones that we've seen. There's a question with headache doctor in Pittsburgh, Dr. Konicki at University of Pittsburgh. Dr. Konicki is a top name in that whole group there. Is supposed to be very good. Heartburn is worse on the Aimovig or Ajovy. We'd have to stop it then. And depression is The question is it worse with one over another? We don't know yet. It's not that common to get increased depression, so we're not sure. We're going to have to see. But there's a lot of unanswered questions. I'm preparing 6 new studies I'm doing on these, and I'd like to write an article on what we know and don't know after 1 year of these. We don't know a lot, and we know a lot, but we probably know about 10% of what there is to know about, even initially dealing with these drugs. So it's the side effects is what the efficacy, the effectiveness is pretty good. It's the side effect profile is the big issue. Now, another question about medication overuse, I can't state it enough that it's unfair to headache patients. They go to a neurologist, they go to a headache center, and they're told, well, you're taking this, you're taking that, and you're getting headaches from it. And they say, well, I've had headaches for 40 years, and I've only taken this for 6 months. Well, how can I get headaches from it? And the person is conflating medication overuse with medication overuse headache, which is much different. So I think that I wrote an article once, medication overuse headache, poorly diagnosed, poorly defined, and overdiagnosed. And it's a real problem because it stigmatizes people and it blames them when they're not causing their own headaches. And also, we don't give them enough triptans. They'll give 9 a month. Well, if you have 18 headaches a month, how long will 9 triptans go? We don't want to run out of triptans, actually. Now, any medicine can wear out. The topiramate, the beta blockers, the amitriptylines of the world tend to often wear out. Years ago, I did some studies on 2,000 patients, and we looked over a year what happens. From 6 months to 12 months, many of the preventives wear out. And only about 45% of people find preventives that work long-term that are really good that they can tolerate. So what do the other half of the patients do? What these CGRP meds do is they just give us another tool, another weapon in preventing migraines and in helping them. And so it probably increases that 45%, and Botox also. So we're probably up to 55, 60%, which means that at least 40% of people still can't find anything preventatively that works long-term. Now, these are actually indicated officially for just migraines, 4 a month, 2 a month, 6 a month. There are some people with 4 or 5 migraines a month who need daily preventives. They have severe headaches, they end up in the ER, nothing works, or they're long, long headaches. Botox, on the other hand, is only officially indicated 15 or more days a month, or migraine days. And that's a problem because some people are turned down insurance-wise from Botox, although Allergan has very good programs at getting reimbursing for the vials and for the injections. Their BotoxSavingsProgram.com is very good. And these Ajovy, Emgality, Amavig have had very good programs at trying to get these paid for also. But Botox is indicated for chronic migraine, 15 or more a month. These drugs are indicated down to any number of migraines. So that's actually a big advantage of the CGRP. There's a question is, in people who are not super responders, do you see people get better and better? And that can happen. Some people are better at 6 months than at 2 months. In general, what you see at the end of 2 months or 3 months is what you're going to see 4, 6, 8 months later. Depression is we haven't seen it that much, and nobody really knows if it's more than one type of medicine versus another with CGRPs. Depression can happen with certain drugs, beta blockers, even some of the anticonvulsants can help, can cause depression. There's a question about pituitary adenoma. The anti-CGRPs do get into the pituitary, so you have all your crucial hormones there, growth hormone in kids particularly, thyroids, and these can be affected, and the companies have not done studies on hormones and the pituitary, so I'm a little worried about effects on pituitary, on thyroid, on hormones with these. The question is daily aura and the risk for stroke. Any auras that are frequent increase our risk for stroke a little bit, but the absolute risk is not that high. So say your risk in a young person, a 25-year-old, for stroke is 1 out of 22,000 young people. If you have auras, it may be, and migraine with aura may increase your risk to 1 out of 14,000. It's still 1 out of 14,000 people. If you add in blood, birth control pills and smoking, it increases it quite a bit. But the relative risk may be twice as high with something, but the absolute risk is still low. So yes, stroke may happen. Migraine increases the risk for a lot of things, from dementia to stroke, but the absolute increase in risk is still very low. So there's a question of people on who have certain blood factors that lead to coagulation problems, factor V in the bloodstream, and probably these drugs are not an increased risk in people with those. And these medicines have been used in people on blood thinners like Xarelto or even Coumadin. We don't know yet if there's going to be rare side effects with that. So the issue is, can we combine these also with other drugs? The good news with CGRP drugs is there's no real drug interactions with all of our oral drugs. So you can stay on Inderal or amitriptyline and triptans, and these don't hurt the liver or kidneys. So they're not cleared through the liver or kidneys. They're metabolized through the lymphatic system. We call it the reticuloendothelial system. So they don't go through your big organs, particularly the liver. Now, the small molecule ones, the GPANs, do go through the liver. So we're going to have to do, if people are on those every day, we'll have to end up doing liver tests. Any medicine can stop working. We can get what we call tolerance to any headache medicine. That happens with any preventive, and it happens with triptans, and it can certainly happen with these CGRPs. We do see tolerance sometimes from Botox where it stops working. Usually, Botox keeps working. And I've had quite a number of people on these CGRPs. We have prescribed these over 1,000 times who do well at 2 months, and they're doing very well at 7 or 8 months. So it's not as if things are going to constantly wear out where they stop working. And then some people, you stop these for a while and you start them again, they'll work again, or you switch to a different one now that we have the 3 CGRPs. It is a problem, communication with doctors. One problem I mentioned is that in the package insert, and doctors have been told with all the lectures that these are really safe, that there's no side effects, and people go in, complain about a side effect that's real, and they're dismissed. And that's why I want to back up the bus, get the package insert changed, and change how we do the lectures. It's not fair to patients. It's also not fair to patients to limit as needed medicine and say you can only take 2 a week or 4 days a month, because it's not reality. You're telling millions of people that you basically can't function half the days of the month. There's a question of Botox with Aimovig, and the person's on Frova, and they're down to 4 a month or so, and it's a miracle. We do hear with these that it's a game changer, a miracle sometimes, and that's one. Now you hear that with any preventive or with Botox, but I think that Botox and these CGRPs have a significantly higher chance of really helping than any of our oral preventives. They're really better. If there's any other questions, I thank you very much. I think that the groups, and particularly this CGRP group, has been extremely helpful for me, but for everybody, and you can see you're in a big boat. Thank you.